modes, presentation mode. Now it's okay.
A very good afternoon. A very good afternoon to all. I am Dr. Subhendu, Senior Manager, Scientific Services from Himalaya Wellness Company. It's indeed a moment of immense pleasure to welcome all our beloved and respected doctors who have logged in. On behalf of Himalaya Wellness Company, I take this opportunity to extend my earnest regards and greetings to all the eminent doctors and our eminent guest speaker today who have logged in. Before we move on to the session, though virtually, let us all together light the lamp as a sign of keeping the flames of wellness and happiness alive. Well, doctor, as you are aware, wellness in every home and happiness in every heart has been the vision of Himalaya Wellness Company since 1930. With your constant support and patronage, we have successfully completed 91 years of trust and service in this field. During these years, we are in constant connect with our beloved and respected doctors through various means. And today we are here in front of you with a talk on the occasion of World Kidney Day. Doctors, as you are much aware, World Kidney Day, which is going to be observed all through the world on 10th of March, that is tomorrow. The Joint Steering Committee of World Kidney Day has declared 2022 the year of kidney health for all. And this particular campaign this year today focus on the theme that is bridge the knowledge gap to better kidney care. So World Kidney Day, besides creating opportunity to raise awareness in the prevention and management of kidney diseases, it also sets a reminder to all health professionals to update themselves on the latest aspects of prevention and management of kidney diseases. And among all kidney diseases, I'm sure doctors, you will agree with me, urolithiasis is one of the most common and oldest health afflictions to the human, and it has remained as a major health burden. And in the past few decades, its prevalence has been drastically increased in industrialized nations as well as the developing nations, including India. In India, urolithiasis affects about 2 million people every year. And that brings the relevance to the topic of discussion today, complications in the management of kidney diseases. To have a deep dive into the topic and to enlighten us, we have with us today one of the eminent urologist and laparoscopic surgeon, Professor Dr. Dulal Kanti Majumdar sir. Dr. Dulal Kanti Majumdar sir is a consultant urologist and laparoscopic surgeon having more than 30 years of experience. Professor Dr. Majumdar has expertise in urologic laparoscopic surgeries and has successfully handled many complex surgeries in his career. He has been a part of many national and international symposia, workshops, and conferences. Professor Dr. Majumdar has been associated with KPC Medical College and Hospital, Kolkata. He has also been associated with Ramakrishna Mission Seva Pratishthan and Vivekananda Institute of Medical Science, BMRC Hospital, and also Mission of Mercy Hospital in Kolkata. So, respected doctors, once again, with greetings from the Himalaya Wellness Company, let us join me in welcoming our eminent speaker, Dr. Professor Kulal Kanti Mujumdar. Sir, it's my honor and privilege to invite you to take up the session, sir. Over to you. With this, I would like to hand over the session to you, sir.
Okay, thank you all. About the World Kidney Day for next 1 year, we will enlighten all of us about the stone formation, urolithiasis. That means stones in the kidney, ureter, bladder, and also in urethra. The topic is complications during the management of kidney stones. We'd like to enlighten about the urolithiasis. That means stones, formation of the stone, why a person is having a stone and the other person is having no stones. The main thing is there is some aggregation of solid crystals in the urinary systems, and there is small needles, and gradually it increases in size, and it's like a small grain to as large as a grapefruit, and they are actually hardened mineral deposits in the kidney, and they are like microscopic particles and gradually form stones. And crystalline forms, the body salts are supersaturated in the urinary system. 80% of the stones are made of calcium oxalate, is a calcium monohydrate or dihydrate, and when 10% stones are infected stones with complex chemical form, these are called struvite stones. And another 10% of stones are cystine stones, uric acid stones, and calcium stones. And formation of the calculi is influenced by increased concentration of stone constituents, urinary supersaturation of the crystalloids, changes in the urinary pH, decreased urinary volume, the presence of infection. Next, formation of the calculi are influenced by increased concentration of stones, urinary supersaturation, that is imbalance in the crystalloid covered ratio, and urinary pH and decreased volume and the presence of infection that modifies the solvent, the urinary systems. That means they becomes crystalloids are gradually concentrated, and they form needles. Gradually, this increases, forming stones. This supersaturation is a continuous of intermittent process, and urine becomes saturated after consumption of large amount of calcium and oxalate. This fluid intake, when this is less, actually we don't take much water during sleeping at the holes at night. Nucleation of forms of crystal nuclei is earlier as poor. solutions. The changes in the urinary pH is phosphates and uric acid are rich acids, and below a pH of 5.5, the uric acid crystals are uh, get together, concentrated together, and form uric acid stones. Phosphate crystals are usually formed in alkaline bead. Urinary volumes are actually reduced due to dehydration. That is, some people have habit of decreased fluid intake. There is climatic influence. That means in very hot seasons, we have to take much water to have a urine output of 1 to 1.5 liter. We have to take around 8 to 10 liters of fluid in a day also. And sometimes if there is a diarrhea, that is fluid loss, then also there will be hydration, and that also may cause formation of stones to start with. The recurrent UTI, actually gram-negative organisms are mainly forms the recurrent UTI. Out of this, Escherichia coli causes 80% of acute infections, and other gram-negative organisms are Proteus, Klebsiella, and occasionally Enterobacters. These are uncomplicated infections that cause. Next sequence of events are supersaturation of urine, there is nucleation, the papilla of the kidney, there is formation of cluster of ions, crystal growth, crystal aggregation, and crystal retention, and gradually stone formation. There is the location of the renal stones. It may be in the minor calyx, major calyx, in the pelvis of the kidney, pelvic junction, any part of the ureter. Sometimes it is at the narrowest position of the ureter, at the junction of the where it crosses the internal iliac vessels, and also at the PUJ junction. These are the narrowest point, and you get stones there. And there are stones also in the bladder, and sometimes when the stones come from the kidneys, that causes retention of urine by closing the urethral opening of the bladder neck. And we get stones sometimes in other areas of the kidney out of the calyx also. And stone sizes and progression of stone formation. Stones below 4 millimeter, these are easily flushed out without medication by taking plenty of fluids. We give sometimes diuretics, optional analgesics, and sometimes antispasmodics. Stones above 5 mm, less likely to be flushed out, becomes larger over a period of time, and if the stones are more than 110 millimeter or more, surgery or lithotripsy are required most of the time. Medical expulsion therapy, there are two types of therapy. One is medical therapy, we start first, and another one is surgical treatment. There are lots of modalities are there. For the medical treatment, we give alpha blockers and also sometimes calcium channel blocker. And we give along with this plenty of fluids, and we medical treatment that is usually given around 3 weeks of time, and it is even for smaller stone that is below 10 centimeter stones, and don't wait for 3 weeks if there is infection, if there is severe hydronephrosis, and if you wait for more than a month, sometimes this hydronephrosis and infection, there may be GFR may be reduced and gradually the improvement may develop. If there is single kidney, high diabetic, or any CKD, don't wait for medical treatment. And stone should be relieved of the stones. For medical management, for calcium stones, idiopathic hypercalciuria, then thiazide diuretics are used. If for uric acid stones, we use allopurinol or diets where the uric acid contents are high, then we give allopurinol or dietary restrictions. And if the urinary citrate is less, we give alkaline supplements, that potassium magnesium citrates. In idiopathic stone disease, we must have plenty of fluids, and along with that, there should be oral phosphates if needed. Medical management for uric acid stones, we give, to reduce the acidity of the urine, we give alkali and allopurinol. If the daily urinary uric acid is more than 1000 milligram, struvite stones, we give, if that is because it is due to some infection, we give antimicrobial treatment, and along with this, the other modalities, that means surgery, we have to do. And cystine stones, we give massive fluids and alkali, and if it is needed, penicillamine is also used. Next, surgical management. Surgical management is we do endoscopic surgery, sometimes laparoscopic surgery, and sometimes open surgery. According to the size, and the status of the kidney, the modalities of treatment is selected. If the stone size is less than 5 millimeters, then wait and watch. And if the size is 5 to 10 millimeters, and if medical management fails, the best treatment is RIRS. That means, and if the stone size is more than 10 millimeter to 15 millimeter, the options are RIRS, ESWL, and PCNL. And if the size is 15 to 20 millimeter, then also we can try ESWL, but usually it requires more than one time. RIRS is also can be done, and PCNL we usually do. If it is more than 20 millimeter, then PCNL is the gold standard first. ESWL may be tried, and RIRS can also be tried. Surgical stone removal. Various alternatives are there. ESWL, extracorporeal shockwave lithotripsy. This is percutaneous ultrasonic lithotripsy. Laser lithotripsy by ureteroscope. And as I told, laparoscopic ureterolithotomy or pyelolithotomy, and open surgery procedure, pyelolithotomy, ureterolithotomy, or cystolithotomy. These are So, in case of PCNL is the gold standard. The stones, locations of the stone, maybe in the minor calyx, maybe in the major calyx, maybe in the pelvis of the kidney, and by shock wave, it is given outside, and ultrasonic shock wave crushes the stones, and it makes its pieces, and after that, we give, most of the time, we use a double stent, so that there should not be no obstruction in the ureter. And this is removed after that. Again, use the USWL, this ultrasonic shock pulses, and this separates the impurities and dissociates the electromagnetic coil or sparking. These waves focused on the stones, and repeated impact breaks this fragile stone. And we usually give at least minimum 500 to 1,500 shock waves for breaking the stones. Sometimes it may be increased also. Yes, the problems in ESWL is there may be residual fragments, and that may impact it in the ureter. Residual fragments require repeated therapy. Kidney injury may be there, and there may be production of hematoma. This is non-invasive, and this is a daycare procedure, and this is operator dependent. Next, PCNL. This is puncture. You have to do a puncture where we can do it by prone position, usually it is done. And also nowadays we do in supine position. So puncture and guide wire is placed under fluoroscopic or ultrasonic guidance. Then we do the tract dilatation, and then after that the scope is introduced, and with the stone is broken, and then we give digestant, double gestant. There may be we give rest to the patient for around 3 weeks time, and satisfaction of the patient is very good for PCNL. All types of stones will be broken by PCNL. This PCNL is the gold standard at present. This is good for larger stone. Clearance is very excellent. 80 to 90% clearance is there. Bleeding is a risk. May need transfusion, but with time, the transfusion rate has reduced a lot. Normally, the rate of transfusion is around 5 to 10%, only 90% won't get blood. Complication is very rare nowadays. RIRS. This is actually a state-of-art technology. There is no need to puncture the kidney. No chance of bleeding is there. It requires actually a wide ureter. If the ureter is undilated, we do staging. That means first we put a stent, and then we introduce the RARS instrument, and good stone breakage is there. This is the best clearance, but this is expensive. We need laser and flexible scope. This is the RARS, this is the flexible scope. RARS flexible scope. RARS is best for stone less than 15 millimeter, best for solitary kidney, so there is no bleeding complication. The recovery period is very short, only the patient may be released on next day evening. After 24 hours, we can discharge. No need to take rest for 3 weeks. Patient may go to, this is the RARS instrument. This is introduced. With the flexibility, we can go up to the minor calyx also, no problem. URS, this is called URSL, ureterorhinoscopic extraction of stone. Ureteric, this is used for ureteric stone only, can be done with lithoplast and laser both. And lithoplast, high chance of upward migration if it is in the upper ureter. And then we have to do PCNL in that case. There is no complication actually. Stone breaking mechanism here, lithoplast, maybe pneumatic lithoplast or ultrasonic lithoplast. This is a cheaper medicine, cheaper instrument. Larger fragment may be broken, and this lithoplast is good also for PCM. Stone breaking mechanism by various ways. Laser, most advanced technology. Very thin fiber are used with tremendous energy. It allows very good flow of water during procedure. Excellent stone breaking capacity. 100% stones are broken here. Thin fiber suitable for RARS. Only thing, it is costly. Laser. Classical stone laser. Usually we use holmium. Frequency, maximum frequency 80 Hertz. The dusting is poor here. Fragmentation is very good. Require high power machine for good fragmentation. Low power machine are slower and time consuming. Require fixed temperature in option filter, very high electrical power. Oleum fiber laser, this is very good. This is 4 times more faster stone breaking instrument. Maximum frequency 2000. This is 25 times higher power than holmium laser. Best for RARS. Excellent dusting of the stone. Require less power. Tissue penetration less lateral injury, and there is no bleeding. Complication of management of stone surgery. Adverse effects of ESWL. There may be acute trauma to the kidney, acute kidney injury, internal bleeding, and subcapsular hematoma also there. Ureteric stents may cause minimal to moderate discomfort, frequency or urgency, and incontinence sometimes, and there may be infection also, which is generally resolved after removal of the stent. Prevention of stone formation. There should be dietary measures, diuretics, urinary alkalization, herbals, prevents nucleation and progression of the size, the gradual increase in size of the stone. There's foodstuffs with high calcium. Those who are stone prone formation, they should not take. They should take less calcium content foods, milk, curds, cream, soft cheese, hard cheese. These contains high calcium level. The minimum daily requirement of calcium should be 800 to 1000 milligrams, not more than that. Foodstuffs with high oxalates, spinach, tea leaves. This tea leaves contains 375 to 1450 milligram per 100 gram of tea leaves. Nuts contain 200 to 600 milligram per 100 gram of nuts. Beetroots contains 100 to 200 milligram per 100 grams. So this should be reduced. Food containing high phosphates and nuts, 13 millimole per 100 grams. Beans, soft cheese contains 30 millimole per 100 gram. Hard cheese around 28 millimole per 100 gram. Liver around 10 to 12 millimole per 100 grams of phosphates. Foodstuff with high urates, the intake of urates should not be more than 500 milligram per day. Calf thymus contains more than 900 milligram urate per 100 grams. Liver contains around 250 to 350 milligram of urates. Kidney contains 210 to 255 milligram of urates per 100 grams. Poultry skin, 300 grams urate per 100 grams. So we should reduce taking these foods. Avoiding factors favoring the formation of stones, dietary rules, the purine-rich foods responsible for uric acid stones, and those who are having gout, they should not take this type of food. Ascorbic acid, after oxidation, they form oxalic acid, which is a local irritant, and this may be form a needles for the stone. Long-term taking vitamin D causes renal damage, increases the calcium output, and formation of renal calculi. If there is vitamin A deficiency, this causes disformation of the urinary tract epithelium, which may also cause needles formation. High calcium intake and low phosphorus intake is also a reason. Prolonged recumbency causes decalcification of the bones, increased calcium in the blood, excretion via urine, and urinary stasis. This causes aggregation of deposits of calcium inside the tract. Alcohol induces gout and causes formation of uric stones later. Endocrine roles, hyperparathyroidism causes 2 to 10% of the entire erythroid population, and these are easily bilateral stones. Decreased secretion of thyrocalcium causes hypercalcemia also. The next avoiding factors, changes in the reaction of urine. Phosphate stones are likely to form in the alkaline urine. Prolonged use of antacids causes the urine alkaline, use of alkalis, and urinary bacteria after they split urea to ammonia, and as a result, ammonium salts are formed and causing the urine alkaline. Urinary infection changes the urine to alkaline form and reduces the urinary citrates. Bacteria adsorbs on inorganic particles, acts as a nidus for stone formation. Production of mucoproteins by the bacteria causes calcium precipitation. Lack of calcium solvents. The chief calcium solvents in the urine are colloids. These are mucin and chondroitin sulfate. These are the two main things. And then the citrates are also some organic acids and some amino acids helps the to dissolve the calcium not to form the stones. I like to say something about the PCNL, the complications, and there are bleeding is a real complications in for the newcomers who are doing the PCNL, and sometimes it causes some bleeding and pseudoaneurysm also, and this may require sometimes some we have to do it. The patient should be admitted, lots of blood may be given, and gradually it stops. Thank you very much.
Thank you very much, sir, for the enlightening speech. It was indeed a feast of knowledge. I hope all the doctors, I hope all had a nice session, doctors. Professor Majumdar has extensively explained the topic, covering all the aspects of kidney stones, its origin, formation, factors, predisposing factors, including the dietary regime which should be avoided, which has to be taken, and medical management in details, as well as the surgical interventions. Well, it was well heard. That is been reflected by the questions being asked already in the chat box. There are a few questions which has been asked by our eminent doctors who are listening to us. So I will take up those questions one by one. I request our respected guest speaker to stay with us for a couple of minutes. Before I move on to the question and answer, I would like to take 3 to 4 minutes of your time to connect to the plant-based medicine and its scope. Considering India is a country of great biodiversity hotspot, as you are aware, respected doctors, out of 36 biodiversity hotspots, 4 are in India. Despite advances in kidney care through the medical management and the surgical interventions, many times certain aspects comes to us as a challenge when we treat the cases of urolithiasis, and first and foremost is the recurrence. Recurrence of urolithiasis comes to us as a challenge in our everyday practice. And as I said, this plant-based medicine has become an integral part of our healthcare system since centuries, and they have immense scope in the management of urolithiasis. They have been scientifically tested and clinically proven and considered to be the safe, efficacious, affordable. And considering India, which is a country where every year 2 million people are affected by kidney stones, it is worthwhile to have some, glimpse of the plant-based medicine Because plant-based medicine has been evolved as an evidence-based medicine from its ethnobotanical use through tests to documentations. Now today, doctors, as you are aware, Himalaya Wellness Company's legacy brand, Cystone, is far ahead from the rest in terms of its quality, safety, and efficacy. Cystone, it was launched in the year 1943. So it is there in the clinical use in India as well as in abroad for more than 79 years. And it's available in more than 75 countries, including around close to 40 countries where it has been registered as a pharmaceutical specialty product. And it is one of the brand having, in the segment with the meta-analysis study. And our quest to provide effective solution continue in order to bring the doses convenience, in order to address recurrence of lithiasis, and in order to address the larger kidney stone. Cystone 4 is been launched, which primarily has got 4 major actions in terms of pharmacological actions. It is anti-lithiatic, lithotriptic, anti-inflammatory, and diuretic. It's a polyherbal formulation. The medicinal plants which makes as an ingredient of Cystone 4 has got well documented. Individually, they have umpteen numbers of research papers published in contemporary journals. So coming to anti-lithiatic action, Sila Pushpa, which is botanically known as Didymocarpus pedicellata, has got anti-lithiatic action. It inhibits calculogenesis by reducing the deposition, by reducing the accumulation and supersaturation of the calculogenic substances. Also, anti-lithiatic activity has been attributed to Rubia cordifolia, which reduces calcium and oxalate and phosphate levels in the urine. It also dissolves the oxalate stones. In fact, there is a study which has been conducted on the particular enzyme, that is glycolate oxidase, and it has been proved that hydroalcoholic extract of Rubia cordifolia downregulates the enzyme responsible for the conversion from dietary glycogen to oxalate, that is glycolate oxidase enzyme. So similarly, documentations are there and evidences are there for this plant-based medicine. Lithotriptic action has been attributed to Saxifraga ligulata. This is a plant which grows at a higher altitude from the splits of the rock. Probably from that observation, the ancient scholars, they could correlate it to the kidney stones, and recent research, including the cell line studies, has proved that it has got inhibitory effect on the calculogenesis. It prevents the growth of the calcium hydrogen phosphate dihydrate crystals, and it also dissolves the mucin which binds the crystals and formation of the crystal aggregation. So besides anti-lithiatic and lithotriptic action, there are some other important pharmacological action which are relevant so far as the management of kidney stones are concerned, as we have seen and been explained by eminent guest speaker, Professor Dr. Majumdar. Stone formation doesn't happen in a day. It's a series of process takes place starting from imbalance in the colloid crystalloid ratio. Therefore, microcrystals, rather the microcrystals agglomerate, and then it forms a nidus in the inflamed mucosa. So anti-inflammatory action therefore is quite helpful in preventing the stone formation, and anti-inflammatory action has been attributed to Cyperus rotundus, Cyperus and Ocimum basilicum. Similarly, stone within 10 or 12 millimeter, when its size gets reduced, diuretic action helps us for the expulsion of the stones. And in Cystone 4, the diuretic action is attributed to Achiranthus aspera, Tribulus terrestris, which increases the glomerular filtration rate. So moving forward, for any evidence-based medicine like the legacy brand like Cystone or Cystone 4, it has been gone through a long list of experimental and clinical studies. Close to 100 clinical studies have been there on Cystone. It is within this short stipulated period of time, it is not possible to discuss all this. But however, I will mention one study which has been done by the competent, and all these studies have been done by the competent authority. This is one such study which is conducted by one of the urologists in southern part of India by Dr. Jayaraman, where efficacy of Cystone 4 in urolithiasis has been evaluated with a stone size more than 5 millimeter up to 12 millimeter. Cystone 4 has been given to the patients at a dose of 2 tablets twice daily for a period of 3 months. And this particular clinical study documented that with the therapy of 3 months, next please, with the therapy of 3 months, Cystone 4 resulted in clearance of calculi and reduction in the size of the calculi to the statistically significant values. Similarly, besides clearance of calculi and size of the reduction, in terms of expulsion rate, if we can break the total number of patients into 2 groups, the patients having stone size from 7 millimeter to 12 millimeter, it was noted, this particular clinical study documented that 53.3% patients, there is complete expulsion of kidney stones, whereas from stone size from 5 to 6.9 millimeter, it is 57% success rate in terms of completion of expulsion of kidney stones. Besides these findings and outcomes, this clinical study also documented significant improvement on the clinical parameters like colicky pain, abdominal pain, dysuria, hematuria, nausea, vomiting, chills, and loss of appetite, and pain on micturition also. Like medical, that's about the medical management. Like these, there are many studies have been there. So besides medical management, when it goes to the surgical intervention, there also Cystone or Cystone 4 has got a role. In that context, I just want to mention one independent investigator initiated study which is done in abroad in Medical University Moscow, where in the cases of lithotripsy, so patients who are undergoing lithotripsy, they have been provided Cystone for a period of 1 month post lithotripsy, and the sample size is 280. And it was noted that combined therapy of Cystone after the lithotripsy resulted in better clearance of the fragments, and it also reduced the occlusive complications like hematuria, pain, and pyelonephritis. So this is one of the outcomes which is related to the surgical interventions where medical management is not successful. Patient has to go for the surgical interventions. There, these plant-based medicines can also play an important role. Similar study was also been done as a pre-surgical preparation. Earlier one was after lithotripsy. Here, Cystone application was given prior to the lithotripsy sessions, and it was interestingly it was noted only 45% required more than 2 lithotripsy sessions, in the contrary to 70% in the control group. Well, doctors, with this, I would like to mention the indication which you know very well, you know better than me. Cystone and Cystone 4 therefore is indicated in urolithiasis. Cystone 4 is indicated in the stone size up to 12 millimeter, crystalluria, and post-lithotripsy urolithiasis at a dose of 2 tablets twice daily. And how long it has to be taken, how long it has to be given, that call has to be taken by the physician or the surgeon depending on the clinical outcome. And as we have, as I have mentioned in the clinical trial we have conducted on Cystone 4, it was given for a period of 3 months. Next. That's a brief note and a glimpse of the legacy brand Cystone and mentioning of Cystone 4. So we have reached to the question and answer part of today's session. I can see there are questions in the chat box which have been asked by the doctors. I would like to request respected Professor Dr. Dulal Majumdar, sir. I will put up those questions to you, sir.
Yes.
Yeah, there is a question from Dr. Tanmay Siddhant. How much drinking water in terms of quantity is needed for the during the medical management? Okay,
yes, actually, for medical management, actually, we tell the patients that the urine output should be around 2 liters according to the atmospheric condition. The uptake the fluid intake may be 3.5 liter, maybe 4 liter, maybe 6 liter, maybe 7 liter, but the target is around urine should be more than 2 liters per day.
Right, sir. So the next question, sir, I would like to ask, yeah, that is on Cystone. I will take up that question later on. The question from Dr. Partha Protim Paul, Staghorn calculus stone are dissolved by medicine. So he is trying to mention whether it is possible to have the medical management in cases of Staghorn stone.
No.
Yes.
For Staghorn stone, surgical management should be done in any form of surgical management, but PCNL is the gold standard for it. But if sometimes the staghorn may occupy all the calyxes, sometimes the minor calyxes also at that time, sometimes or either repeated PCNL may be done, but at times open surgery is also done.
Right, sir. May I put forward the next question, sir? Dr. Gaurav Dev. His question to you, sir. During the medical management, how long one should try in case of ureteric calculi without any harm to the kidney?
Usually, we try around 1 month's time, 3 to 4 weeks. Usually.
Okay, the next question, the next part of his question, there is a high chance for recurrence of kidney stone formation even after the surgical removal of the stone. So what is the solution for that?
Actually,
Professor
yes. They actually, there is no 100% solution, but what we do, we tell the patient to take plenty of water. That means the urine output should be adequate. It should be more than 1.5 liters. If it is better, if it is around 2 liters. And second is to take green vegetable fruit, green vegetables. And third is to take citrus fruit. And also we give potassium magnesium citrates in the form of various names. The liquid form, the syrups we get like Stone 1B6, then portraits, then Noculi. There are lots of things there. This is given actually just the main thing. There is a disproportionate between the crystalloids and colloids ratio. That is for that reason most of the stones are formed, and we get repeated stone formations in patients. Even I did 23 times. I removed stones in a patient in a span of 25 years. They are stone forms. But the main thing, hydration is the most important thing. Second is food habits. And third is calcium containing, that is food habits is there, and prevention of infection. If there is repeated infection, it may also cause formation of stones. And the last but not the least one, there should not be obstruction in any level of urinary tract.
Right, sir.
These are the main points.
Thank you so much, sir, for giving extensive information with respect to that question. The next question, obviously, we have discussed from Dr. Abhijit Kumar Mitra. What are the major food causes kidney stones that we have discussed? Maybe, sir, you can take this as a take-home message during, after this question answer session, during your concluding note. Then one more question from Dr. Abhijit Kumar Mitra. Once again, this is regarding the food. Yes, lifestyle. Sir, can we highlight something regarding the lifestyle, how lifestyle has got an impact? Because today there is a paradigm shift in our lifestyle due to various reasons, long working hours. So, can you have, based on your very first experience in your career, do you have any suggestion regarding that, sir?
Yes, lifestyle. Actually, if a person is a rickshaw puller, he has got lots of sweatings, but taking much less water or fluids. So he is very prone to have stones. We are getting much more stones in northern zones where there is the weather is very hot, but people are not taking adequate hydration. That means adequate fluids and water, something like that. The basic thing is the urinary output should be adequate. Adequate means if a stone forming person is forming stones repeatedly, he is always a stone producer. And we to take citrus food to reduce the calcium containing food, and also if the rarer stones are there like uric acid stones and other stones. One is there should not be repeated infection in the body which may lead to urinary tract infection. That is one. Hydration should be adequate. At least one should take 3 to 4 liters of water if he has got no comorbidities like heart disease, and the ejection fraction should be adequate. And urine output, it should be more than 2 liters per day, and should take lots of green vegetables. And one should take this citrus food adequately. And main thing is water. That means if the urine output is more, the crystalline things, the solutes should come out. It should not precipitate inside the kidney, and it should not produce a nidus, and there should be increase of size and forming stones. And sometimes we get kidneys like this is called nephrocalcinosis. We are getting persons having 100 stones in one kidney, like cysts, small cysts. The main thing is there should be good hydration so that the crystalloid and colloids, there should be some balance so that there should not be any stone formation. We should be free of infection, urinary tract infection. There should not be repeated urinary tract infection, and the food habit. These 3 things is very, very important.
Yeah, thank you so much, sir. One more question from Dr. Mausumi Gogoi. She wants to know RIRS, in which category of stones should be conducted. Can you please explain, sir, the uses of RIRS in which category of stones?
RIRS usually we do stones around 1 centimeter. But nowadays, with thulium laser, up to 2 centimeter of stones may be done inside the major calyx, inside the pelvis of the kidney, major calyx, minor calyx. But not if the ostium of the calyx is very small, then it cannot be done. The instrument should be passed there. That is important. But sometimes we use knife, but it has got some limitation. If the connection of the minor calyx with the major calyx is not good, then other modalities are used. That means PCNL is done at that time. Or if
Right,
the
sir.
stones are smaller, ESWL may be tried.
Right, sir. The next question I would like to take up, Dr. Abhijit Mitra, once again, what is the basic difference between Cystone and Cystone 4? In terms of ingredients, Cystone and Cystone 4 is 1.5 times potent in terms of ingredients than that of Cystone. There are two aspects which we got a feedback from the surgeons and treating physicians, that based on their experience, they had to prescribe Cystone at a dose of 2 tablets thrice daily, which might be inconvenient for a person to take. So in order to bring the doses convenience and in the blister pack, Cystone 4 has been launched, which is 1.5, like one tablet of Cystone 4 is equivalent to 1.5 tablets of Cystone. So 2 tablets twice daily of Cystone 4 is equivalent to 2 tablets thrice of Cystone tablet. And based on our clinical evidences, Cystone 4 is designed to address the recurrence as well as the kidney stone of higher sizes. Next question. In fact, there are many questions, sir. I can understand that you are well heard and it was so informative, and is there any permanent solution for the surgical management for kidney stones? No, I think we have addressed. I think this is the same question in a different language. Permanent solution after the surgery. Obviously, there is recurrences. You have already explained that the preventive measures, even after the surgery, to prevent the recurrences, you have already explained how the measures has to be taken to prevent the surgery. I think that we have addressed that question, sir.
Any other question?
Yes, one more question I would like to take up because we are running short of time. Sir, is there any difference in protocol in managing urolithiasis in diabetic and non-diabetic, exclusively for diabetic individuals?
Actually, in diabetic patient, infection, urinary infection we get frequently. This should be taken care of. And if there is stone formation, and if causing any type of obstruction in the urinary tract, it should be dealt with as early as possible. We should not wait for any medical treatment for that case. If the stone size is more than 5 millimeters or around 1 centimeter, one should not delay. That should be dealt with. Otherwise, the GFR of the kidney may reduce and there may be chronic failure.
And so the last question, many times urolithiasis is associated with medical emergency. So for the general practitioners who are treating and dealing these cases of kidney stones, what are the precautions they should take? What is your advice for the budding doctors?
One
deal
thing,
with the medical emergencies?
medical emergency with urinary stones, most of the time the patient has got severe pain, number one. Number two, along with that, infection. That maybe the blood count may be 20 to 25,000. Sometimes we get the WC count. So, in that case, and the patient may be in shock sometimes. So, this type of patient should be admitted. They should be well hydrated by intravenous drips, and antibiotics should be given before. You must have a sample of urine first, then start antibiotics, broad spectrum antibiotics, and analgesic. But the patient, in that case, if the patient has got a rigor, that means the patient is having septicemia. In that case, the patient must be admitted. Otherwise, there may be any type of catastrophe in that case. So, hydration by IV intravenous fluid, number one, and other symptomatic treatment, antibiotics and other symptomatic treatments like antiemetic, PPI, and painkiller. Should not be try to avoid diclofenac.
Thank you so much, sir. Thank you so much for giving us a wonderful session. It was indeed a feast of knowledge. Respected doctors, you heard Professor Dr. D.K. Majumdar, and he has addressed your questions extensively. Thank you so much, sir, once again. With this, we are moving to the end part of today's online talk. Doctors, as you are aware, this online talk, the educational initiative, is brought to you by the makers of Cystone and Cystone 4 of Himalaya Wellness Company. So with this, I would like to invite our sales manager, Mr. Prashanjit Banerjee, to deliver the vote of thanks.
Good evening to all respected doctors. As we all know, American writer William Arthur Ward was an American motivational writer. As he rightly said, feeling gratitude and not expressing it is like wrapping a present and not giving it. On behalf of Team Himalaya, I would like to thank Dr. D.K. Majumdar for his gracious presence and for being the speaker of the session. Special thanks. Welcome, sir. Special thanks and gratitude to all the doctors on board for your valuable presence, support, and patronage. Sincere thanks and kudos to all Himalayans, PMT, scientific services, IT, design, ZMs, RMs, and all my sales colleagues who join hands together to organize this event also. My deepest sense of gratitude and appreciation to all those who made this event a resounding success. Once again, thank you all, and thanks Dr. Saab for your presence, and Jai Hind, Jai Himalaya.
Thank you again.
Thanks.